Well, friends, uh, we come to this talk, which in fact is a little bit totally different. And I myself was not that much prepared, but anyway, so people wanted me to do this, and especially from the company side. So I thought I'll put few things here as well as whatever the patients as partner is concerned. Uh, what Yes, uh, I think we're going to talk mainly about the diabetic mellitus and diabetic macular edema. It's not that it's a talk which is related to the management and all that. It's the various issues which come up. We know diabetic mellitus has shown increasing prevalence worldwide with high morbidity, and it is a silent disease. Many people, they don't know about it till they come with complications, and that's how they are and sort of picked up. And the problem is, since it is a disease which is lifelong, chronic, so the cost is a big problem here. I think if we look at these figures here, I mean, in 1980, 108 million to 422 million in 2014. So you can imagine where we are going. And so 422 million in 2014, likely to be 642 million by 2040. And more than 60% of the world's diabetic population will be in Asia. And among developing economies, the highest increase in people with diabetes will be in China, followed by India. So I think there are some studies which has been done regarding diabetes prevalence. One was by ICMR in 2011. Here you can see the prevalence of diabetes is from 10.4 to 13.6%. And pre-diabetic population is also 8 to 14.6%. Many of them, they are going to convert. So in 2013, 65 million in India compared to 50 million in 2010. And they have already gone to 73 million in 2017. I think once we look at the diabetes prevalence, the way it has been mentioned here, I think we are leading here in Chandigarh, 13.6%. And although in South also it's more, and in the middle part of the country, it seems it's a little less. Maybe it is also related, like here, to more maybe affluence of people. And diabetes care may be very expensive for patients in low and middle income group countries, since many individuals worldwide lack health insurance. So out of the pocket payment for diabetes treatment may pose large financial burden on these households. So I think that very nicely this in the study which I mentioned here in BMJ Global Health, which is just published recently in 2018. The problem with diabetes is that it involves multi-system. It's not only we are concerned with retinopathy, but there are problems with the cerebrovascular disease, coronary heart disease, nephropathy, neuropathy, peripheral vascular disease in the lower limb, which leads to like ulceration and even amputation of the diabetic foot. So once we come to the diabetic retinopathy prevalence in India, the prevalence of diabetic retinopathy in India is anywhere between 10.6 to 26.2%. Although this is in general, but prevalence, once we look at some of these studies which has been done more recently, one is it's anywhere in the central India, as I said, it is marked, but north is very high, 34%. The prevalence of diabetic retinopathy is 18% in urban and 10.4% in rural area. This was the Sun Dream, the big studies done by Shankar Netralia. And so we understand that it has much more with the urbanization or wherever the more affluence is there. And this speed study, we were also part of this. This is spectrum of eye disease in diabetes. So 98% we all know it's a type 2 diabetes, and diabetic retinopathy is present in about 30%. So these are the patients, those who are visiting these 13 hospitals of diabetes. And the hypertension is the commonest association in half of them, 48%. And from ocular point of view, the lens opacities is the commonest ocular disorder, again in half of them. And what is very striking here is that 11 to 12% eyes were blind at the time. That means one eye, whatever, less than 360 at the time of presentation, which is really alarming. So diabetes have a high comorbid burden. This is regarding the diabetic macular edema, especially in the pseudophakic eyes. With the diabetic control, again, these are the, again, diabetic eyes, but not having diabetic macular. You can see the renal disease, the lower limb amputation, everything in this, you can see these red columns is so high once there is a diabetic macular edema. There are so many comorbid, I mean, it's really striking. And this has been published by Kiss et al. In Clinical Ophthalmology. You can go through the details. A majority of the people with diabetes have at least one comorbid disease, and up to 40% have at least three, increasing the number of visits required to the various. So that's how here it is mentioned, particularly this study by Shiv Prasad et al. In Clinical Ophthalmology, retina specialists, diabetologists, nephrologists, you can see how many visits. These are, so how to reduce the burden, how to reduce the frequency or the burden of visit, that's where the major question comes. So the patient adherence itself is affected by the factors including the age, psychological status. Already they are very, very upset because of the multi-system involvement, expectation of treatment. The treatment mostly for all these things is quite expensive. One has to travel. These specialized treatments are not available everywhere. And the cost, particularly where the patient bear a large portion of the cost treatment themselves. And that is with majority in our population. So we have a lot of difficulties on that. So what is really required is sustained efficacy. So anti-VEGF injections are the mainstay of treatment for diabetic macular edema, which requires, all of us, we know, frequent visits for the administration to maintain visual acuity gain, placing a considerable burden on the patient, the caregivers itself, as well as the whole entire healthcare system. So achieving sustained efficacy with a fewer injection and less frequent visits has been a major focus of research at this time. With new therapeutic options, a lot of these brolucizumab or faricimab or so many others are coming up, and port delivery systems, and which is being developed for especially for ranibizumab, treat and extend regimen, which is being focused more and more because you want to reduce the visits as the number of injections, and sustained release corticosteroids like Ozurdex and Iluvien for various retinal diseases, because these are the ones which are not leading to frequent visits, as well as they last much longer. Of course, Iluvien hardly is available to us and will not be, because it's supposed to be very, very expensive, but Ozurdex is available, which we can use. So mean number of injection in real world, I think I'll not go into detail of this. This you can look at that. This is correlated with the improvement in visual acuity. So these are the letter gains with approximately, if you are looking at the number of injections. So here more than less than 50 letter with 3 injections. And if you want a better, they will keep on, as number of injection improve, the visual acuity improve further. That is what. And so is about the naive and non-naive patient. I think this slide I projected earlier also, and you have to look at this, the burden. So first year, 8 to 10 injection, I talked earlier. Next year, you need something like 3 to 4. And third year also, you will need 2 to 3 injections. So the burden is huge. So what is the real world practice in DME? Vision gains were limited in DME as fewer injections of VEGF inhibitors given in the first year. So this is a study which is published, in fact, recently in Clinical and Experimental Ophthalmology. And you can see the median injection received were 4, although DRCR net mentioned 8. So the real world is, so there are other studies from the real world practice which report similar results and proposed a major reason for inferior visual acuity outcome because of undertreatment. So the poor compliance in patients with DME in real world practice may be due to their work-related obligations, other comorbidities where they have other issues which come up with the body, as well as the major is they have to support themselves. That means the economics plays a major role. So what about corticosteroid? There are three options. Either you have, I mentioned about Ozurdex, Iluvien, or a triamcinolone acetonide. So this is usually indicated first in an unresponsive to anti-VEGF therapy, but it can be given as a primary therapy in pseudophakic eyes, or the eyes which has a low risk for glaucoma or have significant cardiovascular risk. I think they can be primarily started on this treatment. And out of this, Ozurdex is the only one which is already sort of even approved, as well as this is something which is available. And Iluvien is available not in our country, very few countries. And triamcinolone acetonide is a problem, but for a very poor patient, sometimes we may have to use 1 to 2 milligrams if we have no other choice. So the main number of injection in real world studies, this is about the dexamethasone implant. So you can see here again, with the visual improvement gain, the number of injections, mean injections are much less for the similar amount of visual acuity improvement. You can see 1.75 or 1.8 at the upper limit. And in the naive and non-naive patients, again, you can see the visual acuity gain as well as the mean number of injections which are given in the real world situations are much less. So I think there is an advantage, but then we have to understand that lesser number of injections are there, but we have to also monitor them for rise of intraocular pressure as well as for cataract. So the fever injections, you can see here, this is a study which is published in 2014, and this study clearly mentioned the mean number of injection, you go to the last one here, is 8.6 here for bevacizumab and 2.7 for Ozurdex. With, you can see the burden has really come down here. So this is one way of reducing the burden. So treatment of DME with intravitreal injection therapy required multiple hospital visits. And I think I'll not even go to that what are the real issues are. They have to go to the hospital, they have to travel to the hospital, they have to wait in the hospital, they may have to take a day off from their work, which is very frequent, as well as they also need a person, carrier, most of them with them. And sometimes they don't have, if they don't have a family support, which again is a problem to arrange, and it might be a lot of a issue involved with that part also. So multiple visitation in current epidemic is a problem. But during the current epidemic, multiple visitation is risky. We know everybody is scared. We are scared, and patients are much more scared. Besides being exposed to risk of pandemic exposure, the other disadvantage of multiple have been studied earlier by Shiv Prasad et al. Majority of the patient experience anxiety, even when they are not in pandemic, otherwise also, before they have to go for injection. So, and there are a lot of things here which are mentioned in this study. It's a very good study done, that they were they could not relax, they could not sleep. And you can see here that 26% of the patient reported that their sleep was affected a day before they had to go for injection. So multiple visitation in current pandemic, I think you should go through this study, which is in clinical ophthalmology. Then everything is given here, that the whole list, and you can imagine what all that I was afraid. It was difficult to think anything except injection, and all the things which happened there. And also you can see here, again in this particular study, I think a lot of things have been studied. I've already talked about some of these things. So there are so many things which are related, and we have to understand all these things, and we never sort of look at that. So, and the cost, I think this side here was the survey done by our VRSI in 2017. and this is the cost from that. And this has been added here by the company, Elargan itself. So, and you can see here, obviously the eccentrics comes to like almost 23,000, 8,000 here for Avastin, and for eccentric almost goes 50 plus, and Razumab maybe around with the procedure. I mean, it is done. And this, it is longer lasting, as well as it would cost maybe around about maybe close to 30,000 or even less. So in summary, amidst this pandemic, consideration towards patient and treating doctors for social distancing and therapeutic distancing, that is what we are talking, in fact, here. We have to do this therapeutic, and quality of life is important. So for chronic pathology like DME, consideration and planning for the entire year, we can achieve this by either we have something like treat and extend regimen for anti-VEGF, or what we have to do much more at this time, maybe we have to use something like intravitreal steroid like Ozurdex, which might buy more time, less number of visits, as well as it will also decrease the frequency of injection. And I think economics of DME management has to be kept in mind in our country. Individual pays in India for treatment. Insurance coverage and government support is limited. Treatment varies according to the cost outward, affordability, and diverse Indian scenario. And standard of care with some riders need to be followed despite these problems. And we must understand, this is very important, I have mentioned it earlier, often the DME patient would be under-treated and under-monitored because of the various factors, comorbid condition, because of the economy involved, as well as the other factors which comes into play, where frequent visits, loss of work, these are all during the, you see, the period when they are active. So in conclusion, rise of diabetes is faster in low and middle income group countries. I have shown you some of the data. And in 20 to 30 years, 30 to 50% develop sight-threatening diabetic retinopathy. Those numbers are going to be huge. We're going to be treating, all of us, large number of such cases. And economic impact of diabetes and diabetic retinopathy is enormous, leading to suboptimal treatment. So many comorbidities, so many systems are involved. That's how they can't afford everything. And close collaboration of various partners, especially patient as a partner, is urgently required. I think we need to look at these other aspects which hardly talk, which in fact came up because of this pandemic, that so many things are involved. It's not only just giving an injection or just doing the OCT. So I think we need a much more closer collaboration, and somehow all this would help in future. So thank you very much.